I'm going to ask everyone to take their seats. I think we're going to get started. I'm here, I want to thank the organizers for having me here. I'm here on behalf of the Rush Center for Congenital and Structural Heart Disease. My name is Cliff Kavinsky, and I'm the Professor of Medicine and Pediatrics, Director of our section of Structural and Interventional Cardiology. I also direct the Rush Center for Congenital and Structural Heart Disease, and I am the Program Director for our Interventional Fellowship. And I'm here not only representing Rush University Medical Center, but also the Society of Cardiovascular Angiography and Intervention. This society is the voice of interventional medicine in the United States, and we hope to make it the voice of interventional medicine worldwide. And this is our first time doing a cooperative effort here with the International Cardiovascular Innovative Group. And I noticed that it is the innovative group, so I'm going to give you a big dose of innovation with this talk. I'm going to move pretty quickly, so I hope you all can stay with me. So I'm going to talk about a little bit, you can start the timer now. We're going to talk a little bit about currently available investigational therapies for percutaneous mitral and tricuspid valve repair, but I'm really going to focus on replacement. Repair would make the talk much bigger and exceed the time limit I have. I'm going to discuss some of the challenges in developing percutaneous valve replacement platforms for the native mitral and tricuspid positions, and I'm going to show you some of the new investigational percutaneous valve replacement platforms we have that we're working with. So I want to point out just how common valvular heart disease is as we age. We see that aortic valve disease is common, but I want to point out that mitral valve disease and tricuspid valve disease are extremely more common as we age than they are aortic. We all know how big an impact TAVR has had on the management of patients with symptomatic severe aortic stenosis. This has revolutionized and changed the paradigm of how we manage these patients, and this is based on a multitude of randomized controlled trial data that has demonstrated that TAVR is better than medical therapy and either non-inferior or superior to surgical aortic valve replacement. And at least in the United States, there are more TAVRs than there are surgical aortic valve replacements. Those curves crossed in 2016, and they continue to diverge even today. So there is not a single patient with severe symptomatic aortic stenosis who cannot be considered for a TAVR procedure, be they low, intermediate, high risk, or even ultra-high risk. All patients with severe symptomatic aortic stenosis can be considered for a TAVR procedure. And it was our hope that this same success with aortic stenosis would then translate to treating other valve problems like chronic mitral regurgitation and tricuspid regurgitation. As you can see here, chronic mitral regurgitation is extremely common, and the number of patients treated is extremely small. If you look at the European experience, I'm sorry, this keeps jumping. If you look at the European experience, almost half the patients with severe symptomatic chronic mitral regurgitation who are candidates for surgery, less than half of them ever get an operation. Wow. So, although we were very excited about the possibility of extending the success that we saw in the TAVR for a severe aortic stenosis to the mitral valve, there are more inherent challenges with developing percutaneous valve replacement platforms for the mitral position. What are those challenges? Well, the mitral valve is a more complex structure. It not only has leaflets, but it has an annulus, it has chordal structures, and it has papillary muscles, whereas the aortic valve is just a door that opens and closes in response to a pressure gradient. The mitral valve, unlike the aortic valve, is much more difficult to get to. It resides within the heart. And this annulus is not a planar structure, but it is more of a saddle shape. And, you know, the success of TAVR is based on the calcified annulus, the calcified leaflets. Well, the mitral valve oftentimes is not calcified. And in patients who have at least functional mitral regurgitation, the disease may not reside in the valve itself, but may reside in the muscle. And by replacing the valve, you don't treat or cure the underlying problem. And then if you have a platform for replacing mitral valve, how do you get it in position? Do you go retrograde? Do you go transeptal? These are all difficulties for percutaneous mitral valve replacement that really were not encountered with the aortic valve. So there have been a whole host of devices that have been developed for percutaneous mitral valve replacement. They have gone through various early stages and feasibility trials, and valve after valve technology has failed one after another for various reasons. Many failures. But there are several who are promising data to support their use. Now, I'm not going to talk about all of them, but I will point out that 3 of them, that is the tendyne valve you see in the middle. On the left, you have the intrepid valve, and on the bottom, you have the M3. These show promising characteristics, and I'm going to talk about these in a little more detail. Here's the 3 valves that I think, of all the technologies that have been developed, these are the 3 that show the most promise. You have the intrepid, the tendyne, and the sapien. These are the specifications of the 3 of them. They're all listed here. They all have either nitinol stents that are supporting them, or they have a cobalt chromium, as in the case of the sapien M3. And you can see this. I'm not going to go through all the specifications. You can see the delivery sizes are substantial, 35 French, 34 French, or in the case of the M3, smaller, 20 French. And there are ongoing clinical studies with these 3 platforms. We are working with all 3 of these platforms at Rush University. This is the first valve I want to mention. This is called the intrepid valve. It was originally designed as a transapical delivery into the mitral position. You see it has a 2-stent design, and it is a nitinol alloy. And it is designed here, is being adapted for transvenous, transatrial delivery. And you see here we go up the vein and we make a transeptal puncture and we deliver the valve transatrially. And we steer it down through the mitral valve, and you'll see how it works in a moment if you just be patient. Just kind of watch this animation play through. You see it has a 2-stage deployment, 2 stents, sort of a stent within a stent. And that's how it deploys, just so. So this is the intrepid valve. So there was an early feasibility study that was done, and these patients were, of course, high risk or extreme surgical risk by the local heart team. EFs had to be greater than 20%. You can look at the inclusion-exclusion criteria for yourself. And the outcomes of these patients, there were 50 patients. There's, of course, a significantly high mortality rate. These patients are very, very sick in order to get into this early feasibility trial. But the things I want to point out is that there's no device embolization, hemolysis, or thrombosis. And if you look at the effectiveness in eliminating mitral regurgitation, it is highly effective. So we are now launching into a larger trial with the intrepid valve called the Apollo trial. The Apollo trial they have 2 arms. One is a registry arm and one is a randomized arm, which is going to randomize patients to mitral valve surgery versus implantation of the intrepid valve using a transvenous transatrial approach. And this study is just beginning. It's ongoing, and we hope to see very positive results coming from this trial. This is the tendyne valve. This is from Abbott Pharmaceuticals, Abbott Structural, and this valve design is different. It has a tri-leaflet porcine bioprosthetic valve, and the outer frame here attaches to the annulus, and it comes in a variety of sizes. But what's different about this is that it has a tether and a pad. So this valve is designed for transapical delivery. and only transapical delivery. So you can see, and I'll show you in the animation how this works. This is, again, through a transapical puncture, through a left small thoracotomy, and then you deliver the valve up through the apex after you make a puncture, and you'll watch how this goes. And the problem with this technology is that it does require a small left thoracotomy and an incision and puncture of the left ventricular apex and all the problems associated with that. But it was the first percutaneous valve to get into full investigational trial, and therefore we are working with this valve while we also evaluate purely percutaneous transvenous transatrial systems. Here you see how the valve deploys, and then it's anchored in place using this tether, and tension is put on the tether, and then the transapical puncture is then closed and sealed with this pad. And actually, it works quite well. Very effective. And you can see there's early feasibility study for this. Same kind of inclusion criteria. These patients had to be ultra high risk or not surgical candidates at all. Their ventricles can't be too dilated, or EFs can't be below 30. Once again, you're going to see that same higher mortality rates because these are very sick patients. But in terms of eliminating mitral regurgitation, it is very effective. So this is the Tendyne valve. And it is now going into a randomized trial called the Summit trial. And in the Summit trial, patients are being randomized to the Tendyne valve or MitraClip. And you can see the summary of the early feasibility, 97 implant success rate, and you see how effective it is at eliminating mitral regurgitation. And this is the Summit trial, as I said, which is randomizing patients to MitraClip versus the Tendyne valve. And the last valve I'm going to show you is a novel offering from Edwards Life Sciences called the SM3 valve, which has a two-stage deployment. The first, you deploy this anchoring ring. This anchoring ring then goes circumferentially around all the chordal structures and the leaflets. And then that will provide a scaffolding, a target, an implantation scaffolding in which to implant a valve. And you can see in putting this the scaffolding in is kind of tricky, but once you get used to it, it's very feasible. And then once that is in place, you just take a modified sapien valve and implant it right inside that. So this is kind of a hybrid between new technology and existing TAVR technology, because the sapien valve is really it's the same valve that we use in TAVRs, essentially. And you can see the valve just deploys within that framework in the mitral position. And this valve has also gone through early feasibility for severe mitral regurgitation, as long as the EF is greater than 30%. And you see the endpoints here. And once again, the mortality was quite low, as was stroke rates. This data looked a little bit better than the others. And it was quite effective in eliminating mitral regurgitation. So this is also a very promising platform of technology, and is going into a randomized trial, not a randomized trial, a registry trial called the Encircle trial for obvious reasons. And we at Rush are involved in that trial as well, using this for severe mitral regurgitation in patients who are high risk for surgery. This is the criteria for the Encircle trial. I'm not going to go through this in any great detail. Here's a quick example of an 81-year-old who had this M3 valve in place. You can see the anchor, you see the valve inside the anchor, you see virtually no mitral regurgitation. So this technology works quite effectively and has a smaller sheath delivery system and has some real advantages to it. You can see this patient's EF recovered over time. So a couple words on the tricuspid valve before I end this talk. It's a very complex structure, the so-called forgotten valve. Dealing and developing percutaneous solutions to such a complex structure is very challenging, as you might expect. There are transcatheter edge repair systems that are being developed and evaluated in randomized clinical trials, which are showing a lot of promise. And I'm just showing here just how big a problem chronic tricuspid regurgitation is. Many of these patients languish with getting just a little bit of diuretic. Very few of them get surgical treatment. And I want to point out that since we've been working in the tricuspid area, our classification system for TR has changed. Mild, moderate, severe are no longer considered adequate for this space. We have developed massive and torrential for very severe TR, and you can see the definitions for it based on vena contracta and regurgitant fraction and all that. So this is one of the novel technologies that's being developed for percutaneous tricuspid valve replacement. It is the EVOQUE valve from Edwards Life Sciences, and it has a deployment sort of similar to some of the mitral technologies. You see it has a frame and a valve, and it deploys just like so. You watch, it has a little frame that engages the leaflets and secures it. And then the valve deploys secondarily. Like so. So this is the EVOQUE valve. The EVOQUE valve is currently undergoing a clinical trial right now, and it's showing a lot of promise, and this technology may indeed be durable. The other option for percutaneous tricuspid valve replacement is the Intrepid valve. The Intrepid valve that I talked about for the mitral position is also being adapted for the tricuspid position, and it is going to go into a randomized clinical trial later this year. So you'll see this valve in the tricuspid position as well. So in conclusion, I think I didn't talk about TEER very much because of time, but TEER has strong limitations. Percutaneous mitral valve replacement and tricuspid valve replacement technology will develop, but it's going to be a slower and longer process than for the aortic position for the reasons that I have elaborated on earlier. And I think that we'll see clinical trials for both the mitral and tricuspid valve replacement platforms very soon. And I hope to come back to you maybe next year and give you an update on this very important area of work. So with that, I think I'll stop here and move on to the next part of the talk. Thank you. So I got to go change my slides here. Okay. So I'm going to show a couple of quick cases for your viewing enjoyment. Again, from the same place where I work, along with Dr. Suradi, and I'm the same name. I am having some control problems. Okay, 60-year-old female, rheumatic heart disease, prior open commissurotomy in 1971, then had a mechanical mitral valve replacement, 2005, and a tricuspid annuloplasty in 2005 as well. She also has moderate aortic stenosis, persistent AFib. Her ejection fraction runs around 40-45%, pulmonary hypertension, and she's had breast cancer and is at chemo and radiation to her chest as well. So she now has worsening dyspnea, New York Heart Association class 3, edema, multiple admissions for right-sided heart failure, secondary severe symptomatic tricuspid regurgitation. Here's her right heart and left heart pressures. You can see she has marked elevation of right heart pressure. She also has significant pulmonary hypertension. Her mean pulmonary pressure is 44. So this is a sick woman, really not being considered seriously for cardiac surgery. So we had to look for other alternative options for her. Here's what the tricuspid ring looks like. You can see her mechanical aortic valve, and there's her tricuspid annuloplasty ring. She has a 25 millimeter St. Jude mechanical valve, and she has a 28 millimeter Edwards MC3 tricuspid annuloplasty ring. Now, I don't know how many of you think about annuloplasty rings much, and I never used to, but I tell you what, I think a lot about it now. So this patient was seen in our structural heart disease clinic. All the options were considered, and she was felt to be very high risk for a third surgery. So the plan was to try and implant a valve inside that annuloplasty ring to see whether that ring could support a percutaneous valve. And the evaluation started with CT. And I want to just mention a couple words about annuloplasty rings, since I know the surgeons here know it very well, but we as interventional cardiologists really don't. They vary a lot in terms of whether they're partial or complete, partial circles versus incomplete circles, whether they're circular or elliptical, whether they're flat or saddle-shaped, whether they're flexible, semi-rigid, or rigid. So those are all the different parameters of an annuloplasty ring. Now, these are the different types. I show them, I just mentioned what they are: complete versus partial, circular versus elliptical, rigid, semi-rigid, flexible, saddle-shaped or flat. The best type for implanting a valve is going to be a complete circle, which is flexible, obviously. The worst kind is going to be rigid, because those will not change their configuration. So if you try and put a circular valve inside an elliptical rigid valve, well, it isn't going to work. So this is the CT of this lady. You can see that the annuloplasty ring is incomplete. So you might say to yourself, how can you implant a circular valve into a ring which is not incomplete? Just so we understand, I think for the most part, all tricuspid annuloplasty rings are incomplete because they leave an opening by the conduction system. Otherwise, they would damage the conduction system. So all tricuspid annuloplasty rings are incomplete, as this one is. Here you can see in the bottom left the trajectory, if we put a wire into the right lung, what the trajectory of the valve delivery system would look like, and that was what we thought would be the best approach. And you can see in the top left, you see the sac that we will leave behind when we implant the valve in this ring. So we are going to eliminate torrential TR and leave her hopefully with mild TR, because there's going to be some leakage around that open segment where the sac is. Everyone understand that? So the general approach is right internal jugular, because the approach onto the tricuspid valve is more favorable. We chose a 29 millimeter Sapien 3 with pacing from the left ventricle. We used a certitude sheath. I'm not going to get into that. Here's the baseline echo showing the TR. And here we are delivering the valve across the ring. You can see the ring there and the valve across it. The wire is put into the right pulmonary artery. And here we are having deployed the valve. Let's see if I can get this. Having some audio-visual difficulties. But suffice it to say, here's the valve deployed, okay? And here we are on echo, looking at it. It's secure, and there's really not much tricuspid insufficiency. It's well seated. The marked reduction in the TR, no significant leak, despite the fact there's a small sac there where the opening on the annuloplasty ring resided. So she's doing well, markedly improved clinical symptoms, now New York Heart Association Class 1. Her diuretic requirements have diminished. She's had no hospitalizations. So this case turned out to be very good. And, but this is new territory. It's not really approved in our country. We do it kind of as a compassionate use treatment in patients who have refractory TR who are not candidates for anything else. This is going to be an example of a case that didn't go as well. 77 years old, severe aortic stenosis, interstitial lung disease, recurrent heart failure. You can see all her data here, STS score, frailty. Here's her EKG, sinus rhythm, narrow QRS, some LVH. Here's her echo data. I hope you saw that very quickly. Her peak velocity is 4.1, mean gradient 43, valve area 0.9, normal ejection fraction. Here's the echo appearance of her valve. You see it in the peristernal long and in short axis view. Valve looks dysmorphic, calcified, thickened, and stenotic. Here's her coronary angiogram. Really not a lot of coronary disease. Looks pretty good. And here's our CT analysis, which we do for each of our patients. I'm not going to go through this in any great detail. Look at the diameters, about 21.7, areas about 370.8. Here's the tracings that we do on all our patients. We do all these measurements ourselves. We have a structural fellow who uses proprietary software and does all these measurements for us. Here's our calcium deposition. You can see on the double oblique, we look for calcium that encroaches into the outflow tract. You can see on the left image that there is calcium encroaching in the outflow tract, and this gives us some level of concern because this puts the patient at risk for perhaps annular rupture. And of course, we look at the periphery to make sure we can go transfemoral. I apologize, these slides are just jumping on me. This is all our transverse sections that we look at. And our plan was to use a Medtronic valve, which is a self-expanding system because of the calcium in the outflow tract, to go from the right transfemoral, and that was the planned size. So here we are. Here's the wire is deployed in the apex. You can see the valve is being positioned. Let's see, how do I do this? Click. Could you click on that for me? Yeah. You got to click on the image. There. So you see we're starting to deploy the valve here. Click on that one. And you can see we're continuing our deployment. So this is a self-expanding system. And here, don't click on that yet. Go back one. Can you go back once? Now forward. Now just stay there for 1 second. So you can see how constrained the valve is at the bottom. So we did a balloon inflation. Now watch as we inflate the balloon. Did you see that? The valve moved. And it didn't move. Whenever it moves, moving is never a good thing. So it moved up into the aorta, out of the aortic valve annulus. So this valve has embolized. So when you see this as it's happening, you know, your heart sinks and you become very sad. And we were sad. I was sad. Go to the next. So here's what it looks like. You can click on this, play it. You can see we're no longer in the annulus. We're sitting like above the annulus, kind of right over the coronary. So this is not a good place to be. So what you have to do in these situations, there's no way to salvage this. You cannot recapture this valve. You cannot take it out. There's nothing you can do except to snare it and pull it up, either into the descending aorta or up above the coronary arteries and proximal to the innominate, in sort of an inert position. And that's what we did. Here we see a snare is attached to it, and we're pulling it up trying to get it above the levels of the coronaries, and you see it move there. Now the idea is you bring it up, and then you have to deploy a second valve. And here we are getting ready to deploy an Edwards now. Now we're going to a balloon expandable system. This is the Edwards valve. But you notice that the first valve still is over the level of the coronary. It's not high enough. If you deploy the valve here, you'll still have a problem with coronary occlusion. So we have to snare it and pull it up more. And here we are. You can see the valve is much higher. We're getting ready to deploy the Edwards valve, and I think we're going to do it right now. There's the Edwards valve going up. So the first valve you can see is above the level of the coronaries and proximal to the innominate artery. Go back. Play this. Go forward. Play that. So here's the final position. You can see the Edwards sapien valve, and you see the core valve, both deployed. Go to the next picture. And this is a aortogram showing that there's the Edwards valve is in good position. There's no leak, and the situation seems quite stable. Next. And here we see the next day. Flow looks good. I don't see any paravalvular leak. The mean gradient is 2, the peak velocity 1.1, and everything turns out okay. All's well, that ends well. And I think that's the last slide, right? Yes, thank you. Okay, that's all I got.
Dr. Kavinsky, thank you for this very excellent presentation. Very informative for us. We have a lot of questions later at the end of the whole presentation.
I'll be right there.
Yes, thank you very much.
Severe aortic valve disease and coronary artery disease frequently encountered in same patient. Dr. Suhail Hammoudeh, tell us about what we know and what we don't know about coronary artery disease prior to TAVI procedure.
I'm going to talk about the combination that we see in our patients most of the time, the aortic stenosis and the coronary artery disease. And knowing that most of the audience are not actually in practice involved in TAVR or structural heart procedures, I'll try to make it simple and useful for everybody. Since Alain Creppier 20 years back implanted the first TAVI, you know it was once in a lifetime treatment, but now we know that the paradigm has shifted and it is now a lifetime treatment for patients because we started to implant the aortic valve in patients at lower risk, at younger age. So you might see patients with TAVR in whom the life expectancy is expected to be more than even 20 years. We know that coronary artery disease and aortic stenosis, they live together. And if you look at the prevalence of coronary artery disease in patients of aortic stenosis, you can see that it increases with age. If you take the extreme age above 80, it's around 80%. And if you go down with age, it goes down to 37% in patients who are younger than 50 years age. Is the severity of the disease going to affect the outcome of patients with aortic stenosis? Yes. And if we look at the severity of the disease calculated by the syntax score, we can see the more severe the disease, the outcome will be worse on those patients. This is another slide showing the prevalence of coronary artery disease in patients with aortic stenosis, looking at the data from the trials done during the TAVI trip. So if we take the core valve US study done on extremely high-risk patients, we can see that the coronary artery disease was detected in about 80% of the patients. If you go down with severity to high risk, just high risk patients, it's less than 80, between 60 and 70. And if we take the study done on low risk patients, evaluate low risk patients, we can see that the incidence or prevalence of coronary artery disease was just about 10%. So what are the connecting points and why we are worried about coronary artery disease and aortic stenosis? One of the things that the case that presented by Dr. Omar and the case presented by Dr. Raed, so we have to keep the access to the coronary arteries after doing the TAVI procedure. So the topic, commissural alignment and why it is important. In this cartoon, you can appreciate on the left side, this is the valve, the origin of the coronary, and you look at the commissures, we see that they are fully aligned to the origin of the coronary. The commissures or commissural posts are not blocking the origin of the coronary arteries. And this is good because when you take this patient after that to the cath lab, you actually will be able 100% to access the coronary and do things, especially when those patients come back with acute coronary syndrome. If we look to the right side, you can see that the commissures of the valve, the commissural posts, are hanging or blocking the origin of the left and right coronary, and this is total or commissural misalignment and will make your life miserable when you try to make access to engage the coronary arteries in this group of patients. How difficult to engage? It depends upon the valve implanted. If we take the balloon expandable low frame, most of the times it's easy to do that. If you go to high frame valve with intraannular leaflets, it is moderately difficult. But if we go to the high frame supraannular valve, the evolute valve, because the valve is above the annulus, it is almost next to the coronaries, it will be the most difficult valve to engage after that. And the most difficult patients really to engage is coronaries after implanting the TAVR is in patients with valve in valve, because you will have double layers of metal, of leaflets, of cusps, so it will be very difficult to do that. Why is that important? It's not just how to do the TAVI, but how to treat acute coronary syndrome in patients after TAVI. Now the procedure is growing, more and more patients are getting the TAVR, so soon we'll start to see more and more patients coming with acute coronary syndrome. Most of the patients will be coming with non-STEMI, 90%, and 10% will be coming with ST elevation MI. And we know that the acute coronary syndrome should be treated and those patients should be revascularized. Otherwise, as you can see, the mortality rate will be higher and the survival will be much less in this group of patients. When they compared the PCI in patients with TAVR valve against the patients who are in native valves, you can see that the balloon to the door to balloon time was significantly prolonged, as you can see in patients with TAVR valve, and you can see that the failure rate to engage the coronary and to do the PCI in patients with acute coronary syndrome was almost at 15%, which is very significant and not allowed. This is just to show you one case presented somewhere, and this is the patients after portico valve who came with acute coronary syndrome, inferior MI, and even expert doctors were trying to engage the right coronary and they failed to do that. And when they did the CT scan after that, they could see that the commissure, there was misalignment between the commissures and the origins, and this is why they were not able to engage the valve. In an interesting re-access study, they looked at 300 cases, patients doing the TAVR case, and they did coronary angiogram before putting the valve, and they repeat the angiogram after doing the valve, just to see how often it will be difficult to re-engage. And we found out that in 7.7% of the patients, 23 patients, it was impossible to re-engage the valve. And the most And the most significant predictors, what the type of valve, as you can see, the evolutor was the most difficult one because it's high frame and supraannular, and the level or the depth of deployment. The higher the valve, the more difficult will be to engage. Although we try to do higher deployment of the valve just to preserve the conduction system and to minimize the need for permanent pacemakers during the TAVI procedure, and the ratio between the valve size and the annular size of the patients. Just practical points for everybody who might see patients with acute coronary syndrome after TAVR procedures. It's better to start with an angiogram to give you just some information, what's the valve, what the kind of valve, and where is the origin of the coronaries. Maybe it's better to go transfemoral than transradial because this will give you more maneuvers that you can do. Undersize your catheter for 0.5, and don't try to go deep as we do in patients with native valve, putting down the catheter and go from down up. You have to do it from above the valve, from above the origin of the coronaries just to engage, and don't lose much time trying to selectively engage. If you cannot do that, just do semi-selective injection, put the wire in, and try to use the guide catheter extension to get inside. The other point that I have to emphasize is the coronary obstruction immediately and later after TAVR, that it could happen on the table, minutes after TAVR, hours after TAVR, and it could happen actually later on, as the case presented by Dr. Raed today. And we know that when it happens, it's really a disaster. How often it happens? We are lucky that it's really not that often, but we have to be ready for that. It's most commonly when you do valve-in-valve. It is less common, the least common in self-expandable valve, balloon expandable valve, and it is more common in balloon expandable valve and less common in self-expandable valve. What do you expect when this happens? You expect a disaster, and death actually is imminent if you don't do anything. The mortality if you don't do anything is 100%, and if you do something and you don't succeed, it is 100%. If you send patient immediately to CABG, the mortality was 50%, and if you do PCI and it is successful, the mortality is 22%. How can we predict the occlusion? We have in details to study the CT done before, and this will give us all the hints and the details, and this is all the risk factors that can predict the occlusion. How can we be ready for that? It's better to protect the coronary, putting the wire and the stent inside before deploying the valve. If you predict that this patient is going to be high risk for coronary occlusion, and if you see that immediately after putting or deploying the valve, you just put the stent in the proper position and you inflate the stent and you will get it right. This is an example of occlusion due to the shifting of big chunk of calcium toward the ostium of the left coronary, and you can see that even stenting just the LAD with the ostium is not enough, and you have to go back with chimney technique, putting the stent in the out. So what's the dilemma when you treat patients with coronary artery disease and aortic stenosis? How to treat and how to start, and you are at the crossroads. So you decide to do TAVI or to do SAVR. If you do SAVR, most of the time the surgeon will do the grafts with SAVR, but if you decide to do TAVI, you have to decide to treat the coronary artery disease medically or to do PCI. If you decided to do TAVR, so you have to choose the valve between self-expandable, balloon expandable, or mechanical expandable. And if you have to do TAVI, so you have to do PCI to the patients. We have to decide when to do it before TAVR, to do it at the same time, the same setting, or to postpone it and to do it after deploying the valve or later on in weeks. So if we are going to do it in the same session, we have to decide to do PCI first or to do TAVI first, and every option that you can choose is have advantages and disadvantages. If we do TAVR actually in the same setting with the PCI, you will have long procedure, more complication, more contrast that you have to use. If we do PCI before TAVR, the main issue that the patient will be in dual antiplatelet therapy, and this will increase the incidence of bleeding during the procedure and the access site complication that might happen after that. And if we try to choose PCI after TAVR, you will face the issue that we talked about, the issue of accessing and engaging the coronary will be more difficult in those patients. How the severity of the disease is affecting the outcome, I just mentioned that. This study done in 2017, and you can see that in curves. It is better not to have coronary artery disease. If you have coronary artery disease and it is obstructive, it is bad. And if you measure the severity of the disease by calculating the syntax score, and the syntax score above 22 is the worst patient, and you expect the complication with this kind of patients. So if we take as a reference patients without coronary disease and we compare with them patients with severe disease, we can see that the hazard ratio is doubled. And even if the patient revascularized and revascularization was incomplete, we still see that the patient is still at increased risk. Actually, till now there is no big randomized trial comparing what to do with the coronary artery disease in patients going to TAVR. This is small study activation done in small group of patients, compare randomized patient to do PCI pre-TAVR or just going without that. And you will be surprised to see that the results at 1 year, not more, that the death rate and rehospitalization rate is the same with and without PCI. At the price of paying that, we pay the price at 1 year with significant increase of the bleeding issues. This is another study published recently in 2022. It is not randomized, a prospective study comparing patients with PCI and without PCI before TAVR. So the same thing, that survival, you see that the survival was affecting after TAVR with patients with obstructive disease, 68% versus 55%. And the good thing about this study that they followed patients not just at 1 year, at 2 years, they followed up to 5 years. And as you can notice that at the year 2, actually there was no difference in the outcome, even with the presence of obstructive disease. So we have to extend the follow-up more, up to 5 years to see the difference. Same thing happened with cardiovascular death. We can see that cardiovascular death was much higher in patients with obstructive disease, 25% versus 15%, although at 2 years, as you can see, the difference still not that much. The severity of the disease affecting both, yes, it is the cardiovascular death, as you can see with patients with syntax score less than 22 in red, it is around 24%. The survival, the cardiovascular death, 24%, were in patients with syntax score more than 22, which is the most severe disease. We can see that the cardiovascular death is much higher. Same thing happened if we talk about the severity of the disease and the survival. So what about doing PCI in those patients before? Are we going to change the outcome? In theory, we expect that, but actually in this study what they found, as you can see on the left side, that patients with PCI versus no PCI at 5 years, actually there was no difference, 56 versus 53%, while at 2 years actually there was still no significant difference. And same thing happened in survival at 5 years, 53 versus 52%. We know that the severity of the disease affecting the outcome in those patients, and we'll face
Dr.
the
Suhail,
dilemma.
we are very late in time. Maybe you give us
Okay, 2 minutes.
1 minute.
1 minute. The dilemma in patients with coronary artery disease with TAVR, how to do and what to do to proceed for revascularization or not. What we know that every patient should be evaluated fully, and we have to evaluate the severity of his disease, knowing that this is going to affect the outcome. In which group of patients we have maybe to proceed with the revascularization before doing the TAVR, maybe in patients in whom we are going to do valve-in-valve because we'll have challenges in accessing the coronary in this group of patients after that, maybe in patients with higher ischemic burden and the bleeding risk is much less than in this group of patients, maybe in patients who are at younger age because we expect the survival will be 20 years or more, maybe in patients with single vessel disease with significant hemodynamic, significant lesion in the proximal bar to do it before doing the TAVI. And thank you. I will finish with this slide.
Thank you. Thank you, Dr. Suhail, for this very nice presentation. I enjoyed very much. In the era we are doing TAVI for younger patients and low-risk patients. It's a very important topic. Our next presentation, Dr. Hussam Suradi from the USA. Tell us about the Transcaval TAVR.
Good morning. Thank you for having me again today. We'll stay in the TAVR space. Also, I have 5 minutes to finish up, so I'll try my best. So we're switching gears a little bit and talking about alternative access approach in patients undergoing TAVR. So I'm starting with a case. This is an 83-year-old patient with severe symptomatic aortic stenosis who had multiple comorbidities, including low EF, history of left carotid stenting, severe COPD requiring nasal oxygen, with STS estimated at close to 6%. He was seen in our structural clinic, and he was deemed to be high risk, mainly due to his lung problem. So, as you know, every patient who goes through TAVR gets through an extensive, detailed CT assessment. And what was striking about this patient that his peripheral vessels were very bad, very small. I don't know if this is projecting well, but his peripheral vessels on both sides are less than 3 millimeter, which is prohibitive to undergo transfemoral TAVR procedure. So, as we know, 90% of TAVRs, they undergo transfemoral approach, which is the preferred way of doing the procedure, and about 10% we have to go through alternative access. Amongst these approaches are transapical, transaortic, transcarotid, which is becoming one of our most preferred access approach, and transaxillary or subclavian. In the past, I would say probably in the past 4 or 5 years, there's this new innovation, what we call transcaval, which basically means getting access from the venous side into the aortic side to facilitate getting a sheath up into the aorta and performing the TAVR procedure. And you would think how this is possible. If we poke a hole in the aorta, the patient's going to bleed to death. How is this going to happen? But we rely really on the higher pressure inside the retroperitoneal space to direct the blood into the lower pressure within the venous system. So you're basically creating a fistula, and the blood would stay within the intravascular space rather than going outside into the retroperitoneal space. And this is an example, I don't know if it's working. So this is, for example, the aorta, and this is the inferior vena cava. If we poke a hole in the aorta by itself and there's no hole in the inferior vena cava, the blood is going to extravasate. It's going to go out in the retroperitoneal space. Patient's not going to survive this. However, if there is a fistula that is connected between the aorta and the inferior vena cava, again, the higher pressure in the retroperitoneal space will allow the blood to go preferentially to the lower pressure in the inferior vena cava, and therefore the blood stays within the intravascular space. So let's go over step by step. I have difficulty. Okay, so going step by step over the transcaval approach. CT is very helpful so that we would find the target access site, we would find a spot where it's free of calcium, preferably. It will help us in knowing exactly the distance between the IVC and the aorta, and if there's any structure in between, most importantly, bowel, that would possibly be in that space. So if kidney function permits, we usually like to start with doing an aortogram. And again, this helps us in co-registering our mind of where is our access site in relation to the vertebral bodies. Based on the CT, we were planning to go around between the upper edge of L3. And one other thing that we do is we do a dry cine, and this also helps us in seeing exactly where the calcium burden and try to pick a calcium-free space upon puncturing. So we prepare our crossing system, which consists of an 014 wire. We usually go with an Astaro 20-gram tip, which goes through a microcatheter we call a piggyback converter. This piggyback is an 014 basically microcatheter, which goes as well through an 035 microcatheter, which is the Navi cross. And the back end of the wire, we basically scratch that and we attach it to a bovie to deliver electrical energy when we're crossing the vessels. So now we have our equipment ready. We have either an IMA or RDC guide in the inferior vena cava, and we have a GR4 with a snare sitting in the abdominal aorta. And it's very important to use two views to align your crossing projection. So basically you need to align the catheter within the loop of the snare. And once we're happy with the position, we electrify the wire and we cross it, we push it from the inferior vena cava into the aorta. It's very important to stop so that you don't go beyond the aorta. And one test that you can check is without electrifying the wire, you push the wire and you can see that it's buckling, which tells you that it's inside the aorta. Once it's there, the wire is snared, as you will see here shortly. And then the guide catheter would be pushed upwards towards the descending aorta. So now we have a rail from the venous side to the arterial side. Following that, we deliver the piggyback, the microcatheter, which allows us to advance the other 035 microcatheter, which is the Navi cross. And once we have the Navi cross in the aorta, the snaring system is released and the wire is taken out. And we advance a very stiff wire. We usually prefer going with a Lunderquist wire that you see here is going through the microcatheter. And then the rest of this would be simple. We just basically take the transfemoral delivery sheath from the venous side into the aorta and allows us to do our transcatheter aortic valve replacement, which you see here. Then comes the step of closure, which is the tricky part here. We always use a body wire. We usually advance an 014 wire, such as a BMW or Spartacord wire, and leave it as a safety net if active bleeding goes in and the closure device doesn't work. We use an Amplatzer duct occluder pretty much in all cases. And we use a steering delivery sheath that goes through the 14 French Edwards sheath. And this helps us in aligning the desk of the Amplatzer occluder against the arterial wall. One thing that is very important to remember is when you pull the sheath back from the aorta, you have to pull it all the way back to the IVC. Don't just pull it back a little bit so that you wouldn't occlude the IVC opening. So as you see, we pull it all the way back to the IVC. This is very important. Otherwise, the patient will bleed into the retroperitoneal space. And here you see the deployment of the Amplatzer duct occluder. And this is basically the left desk is deployed and the sheath is basically pulled out. And we still have the device connected to the cable. We do an aortogram just to make sure our position is good. And here you can see the fistula between the aorta and the venous side. And the patient is totally hemodynamically stable during this. And we were very happy with the position of the device. So at that time, the cable was detached. And the 014 wire, the body wire, pulled out. And one thing that I forgot to mention is before we do all of this, we always reverse the heparin. So we give protamine before we do all of this. And just a few minutes of observation, repeat the angiogram, and you'll see complete closure of the access site. So this has been studied in the Transcaval IDE trial, which was a multi-center study that had about 100 patients. Success rate was very high, 99%. There was one failure to cross. There were no deaths related to the Transcaval approach. There were some patients required some blood transfusions, had some bleeding, generally higher than the transfemoral approach, but was relatively acceptable given their other comorbidities. And in this study, about 1/3 of the patients, they have full closure of the fistula at the end of the procedure. And then about another 60% of patients, they still had a fistula connection between the aorta and the IVC, and less than 2% had an active extravasation. It's very important to have bailout equipments ready, such as covered stents, balloons, just in case there's an active extravasation to treat the solution. So what's the fate of these patent fistulas? Based on this study, most of these fistulas will close eventually. In about 1 year, about 86% the fistulas are closed, and there were no fistula-related heart failure or morbidity related to patent fistulas. Recently, this is a paper that was published, JACC Interventions, and they compared transcaval to transaxillary TAVR. This is basically a propensity matched analysis from the TVT registry. And what was really interesting about this study that patients who underwent transcaval TAVR, they had lower stroke risk compared to transaxillary, which makes sense. You know, axillary is very calcified, a lot of disease. Manipulating the big sheath across the axillary artery can push some plaque or clots into the cerebral circulation, and that's why it's associated with higher risk of
Dr.
stroke.
Hussam, it's a very good presentation.
This is the last slide, so perfect timing. So. Yeah, so basically transcaval is a transfemoral approach, and it has a really great data and great success rate. And this can be also used in non-TAVR situations, such as if you need to use VA ECMO or tandem heart or even TAVR procedures of patients who don't have good peripheral artery access. Thank you very much.
Thank you, Dr. Hussam. Transcaval approach is definitively a very good approach, alternative approach to patient with very bad femoral access. It's a very interesting topic, structural heart session today. We thank all speakers, Dr. Kavinsky, Dr. Suhail, and Dr. Hussam. We have time just for 2 or 3 small questions. If anybody have question from the audience. If nobody, I want to ask Dr. Suhail a very important question about this very important topic. Why we don't make in this patient just CABG plus TAVR, if it may be the straightforward way and better outcome in this patient with the aortic stenosis and coronary artery disease?
Yeah, this is how the surgeons talk. But it is an option. TAVR, you know now with TAVR is going down and TAVR is going up. More patients will
But particularly in this
TAVR.
patient.
It is, this is unanswered question, you know, and even the surgeons, they try to do patients with aortic valve replacement and CABG. And we know that the mortality when you're doing that, when you extend your surgery to CABG, you increase the mortality by more than 10 or 15%, and nobody will like that. So the question is, not every patient with coronary disease should be actually revascularized. Very small group maybe should be selected just to do that.
Okay.
Can I ask question to Dr. Kavinsky?
So
there's never really been a study looking at TAVR patients with coronary disease and randomizing them to just doing the TAVR versus treating both. It's tradition to treat both coronary disease and replace the valve at the same time as surgical intervention. But there is about to be a randomized trial starting now called the Complete TAVR trial. This will take patients with incidentally noted coronary disease amenable to PCI. They will be randomized to performing TAVR and then PCI versus TAVR and then just medically managing the coronary disease. And the reality is that much of the coronary disease that we find incidentally noted that is bypassed at the time of TAVR plus CABG can just be managed medically. There's no data that says that bypassing those lesions really does anything.
Okay, thank you.
I have a question to Dr. Kavinsky. With that valve that slipped up, so we have two valves functioning. Is that going to affect the coronary perfusion, the diastolic pressure?
No,
and should we proceed to disable the proximal one?
No, I think the valves are working in series. You know, the first valve that's up in the aorta is pretty much inert. It opens and closes with respect to aortic flow. I don't think that coronary perfusion is compromised because the coronary perfusion pressure would be pretty much the same.
Somebody will proceed and stent inside.
No, I don't. All that will
just
do
to
is
disable
it
that.
will add more metal and more material, more foreign body for infection and thrombosis.
There's one question here.
I have a question for Dr. Kavinsky regarding the case of embolization. Regarding the case of embolization, why it happened, whether it's related to the undersizing of the stent or it is high implantation, because you know that in this particular case, in this type of valve, when we are implanting it, if we are going to completely release it, we are going to take a cine to be sure about the position. My second question that in the case, in the scenario that imagine we don't have a balloon expandable stent on the shelf, we have only this kind of stent. If embolization happens, are you going to proceed to implant the second evolute R stent or going to send the patient for surgery?
There's a lot of questions there. So what I wasn't able to show in the interest of time was that when we try to employ the valve extremely high to avoid heart block and a need for permanent pacemaker. So we're constantly trying to deploy the valve as high as possible. In this particular case, the valve was deployed too high. And you can see that the base of the valve stent is constrained, which is why we had to do balloon valvuloplasty after we deployed the valve. The valve was too high, the base was constrained, and that was the reason why it embolized, because the minute we inflated the balloon, it lunged forward. In terms of putting a second valve, you could have put a second core valve there. There was enough room, but I thought that having a balloon expandable system with a lower profile, when we already had put one core valve, was the right approach to take.
Thank you.
الدكتور
أيمن تفضل.
Just a quick question, Dr. Suhail. I know when we put in a TAVR and there is CAD, we treat it. But now we're going to be putting in low-risk people. These people are going to live 20, 30 years. And trust me, it's a nightmare doing an angioplasty on a TAVR patient. It's not only the leaflet, it's really the metal. You're hearing metal. So those people will live another 20 years. So we will be facing, this is going to be a nightmare for us and for the patients. I think hopefully down the road there will be a design issue where you leave like holes or circles where the coronaries come out. Otherwise it's going to be a huge problem. We're talking about future, not the people with
A good idea. Maybe.
Waiting for the holes to come out with the valves. هو يعني when they looked at the valve that we are using now, the accessibility is really possible in more than 90% of the patients, 93, 92%. But the worst group that you're going to face when you implant a valve in somebody who is 60, and the duration of the valve, we know that it will survive. Any transcatheter valve will survive for 10 years, and you need to put the valve in valve, and now we'll start to face the difficult issue because accessing after valve in valve will be more and more difficult. Maybe at that point something will come out.
Thank you very much. We have just 5-minute break.
Thank you.
Dr. Hassan, last question, very fast.
Thank you. My question for Dr. Kavinsky. Here, behind you.
Behind you, Dr. Kavinsky.
I wanted to ask about Percutaneous MVR. You showed us two delivery for MVR delivery system. One is transfemoral and the other transapical. My question is, there's a criteria to choose one over another, or you two different valves? I know, but I think transfemoral less invasive, but you choose another valve, transapical. There is any criteria?
So the transapical platform was the first one to get approved for trial. So it was first there. The future is in transvenous transatrial. The transapical platform, I think, is not durable over the long term. The future lies in going transvenous, and that's the way all the platforms are going to look as we move into the future.
شكرا جميعا. استراحة في بريك 5 دقائق أو 4 دقائق. شكرا جميعا.